طيب بسم الله الرحمن الرحيم. We're going to start our second lecture, which is about bone tumors. Bone tumors are classified into primary bone tumors and secondary metastatic. The primary bone tumor can be benign or malignant, depending on the histopathology. And the classification of these tumors depends on the normal cell of origin. Then it will be differentiated into malignant or benign cells. Again, this is the classification. So benign and malignant. Malignant can be primary, meaning it originates from the bone itself or the soft tissue surrounding the bone, or can be metastatic secondary, which is a transformation of a benign tumor to a malignant tumor. And the most common is the metastatic type. So if the patient has if the patient having like breast cancer or colon cancer can metastasize to the bone, the spine, and the other musculoskeletal part. So the primary bone tumors defined or named after the cell of origin, as we mentioned. So might be from hematological origin, like multiple myeloma or lymphoma, and can affect the bone. Could be chondrogenic, meaning originating from the cartilage, benign like chondroma, osteochondroma, and so on, and malignant like chondrosarcoma. Osteogenic, meaning originating from the bone cells itself, benign like osteosteoma, and malignant like osteosarcoma, and so on. So it depends mainly on the origin of the normal cell of origin. And when we evaluate any lesion in the bone, so what happens usually, a patient comes to you in the clinic or in ER complaining of pain in one of their limbs. So the first thing usually we do, especially if the patient having one of the red flags, we would do an X-ray to that limb or to that part of the body, and we can see the X-ray. So the X-ray is the first line to identify a bone lesion, which might be a tumor. So very important to know the age and the sex of the patient. So the age is very important because most of the primary bone tumors, if not all, it comes in children below the age of 18. And if you have a bone lesion at the above the age of 50, most likely it is metastatic tumor, and you have to find out the primary. So age of the patient is very important when evaluating any patient with a bone lesion. Then we start to look at the X-ray and see if it is single lesion or multiple lesions. Then we decide or look at the location. Where is it exactly in the bone? Is it in the metaphysis, epiphysis, or diaphysis? This will help us to tell what type of tumor. So every tumor has a specific location. Most likely they will have a specific location that will help us to identify the tumor. Then we look at the location in the which bone, as we mentioned, and which part of the bone. Then, the most importantly, we look at the morphology of that lesion. So we have to ask ourselves almost 7 questions about any lesions in the X-ray. So if you see a lesion in the X-ray in the bone, you have to see or to look at multiple things. We will go into details because it's very important and will tell us this tumor or lesion most likely is malignant or benign, and will help us to identify and treat the condition. So when you evaluate any patient, you go with the history, physical examination, investigation, labs and imaging. Then we do the biopsy to confirm the diagnosis. Then we start the treatment. Radiography is very important. Before we go to radiography, I want you to, just in history, we have to take detailed history of the patient. So if a child comes with like leg pain, no trauma, you go into details, the red flags, any night pain, which could be the key point in knowing that or suspecting that this patient might have a tumor. So if the child has a night pain, you have to investigate that further. Could be nothing, ولكن you have to exploit that more with more investigation, more history, and to make sure if an elderly patient has the same condition with pain in the back or in the leg, which is mostly at night, you also have to investigate and do a full systematic review to make sure that you're not missing a primary tumor for this patient. Again, for the very important looking at the X-ray, we have to answer a few questions that will give us a clue what kind of lesion this is. So we have to know the site of the lesion, so which bone it's involved and which part of the bone, okay? Then the most important is the borders of the lesion, so the zone of transition. So if the lesion has sharp, clear edges, most likely it is a benign tumor because it takes longer time for the borders to become sharp and very clear. But if the borders are hazy, they call it wide zone of transition. This is most likely, it's an aggressive tumor that's growing very fast and the body cannot contain it or the bone cannot contain it and make sharp edges around it. What type of bone destruction? Periosteal reaction, matrix of the lesion, nature and extent of soft tissue involvement. We will go into details about all these conditions. So when we look at the lesion in the bone, we determine the site. As you can see here, is it in the epiphysis, metaphysis, or diaphysis? Each tumor most likely has a specific site. This all helps us in the diagnosis. Then we look at the borders. So if as you can see here, the borders of the lesion is very sharp, very clear. You can tell the borders from the normal bone. Then you look at the matrix, which is inside the tumor or the lesion. Is it bone forming? We call it osteolytic, osteogenic, or osteolytic, meaning there is no bone inside. Then we look at the periosteal reaction. As you can see here, you might have like a sun ray periosteal reaction, unclear, or is it a solid periosteal reaction? I will show you X-rays telling you all these things. Is it single? Is it multiple? Then we look for soft tissue. So if there is a bone lesion with a significant or large extension in the soft tissue, you can see the shadow in X-ray and can tell you if there is bone or not. So we look at this to differentiate between malignant or aggressive tumor and benign or non-aggressive tumor. You can see the borders here, sharp, clear borders. And you can see here, the borders are hazy. You cannot tell the cut point between the lesion and the bone. It's hazy, wide zone of transition. This is one. The periosseal reaction is irregular. You can see it, sharp, irregular periosseal reaction, while in the benign lesion it will be a solid, again, clear periosseal reaction. Inside the tumor, is it organized or it is primitive bone destruction, doesn't have a specific pattern? It is primitive, so most likely it's an aggressive process rather than in the benign tumor. This is for the just a little bit advanced for you, but just to know that knowing the site where is the lesion itself can help us a lot in determining what type of tumor. So border of the lesions, again, it's very important. So if you have sharp sclerotic, meaning most likely it's a benign tumor, very clear edges. If you have sharp edges, but the tumor itself is lytic, meaning the tumor has no bone inside. Here, if it is sclerotic, meaning that there is bone inside. Lytic, there is no bone inside, but the edges are clear, and you might have ill-defined borders, wide zone of transition, so you cannot differentiate between the tumor and the bone itself. There is no clear cut between them. Site, again, will help us in the spine if the lesion in the body, anteriorly in the body, most likely it is malignant, or if it is in the posterior part of the spine, in the facet, TB, or spinous process, most likely it is benign. Periosseal reaction, there are many types of periosseal reaction. We have the benign type, which is usually solid, regular, with no up and down waves. But when you look at the malignant tumors, most likely they will have interrupted, unclear periosseal reaction. I'll show you there are onion peel or onion skin and sunburst periosseal reaction. As you can see here in the X-ray, the periosseal reaction here, it is called sun ray. زي أشعة الشمس, you can see it is a periosseal reaction which is characteristic for osteosarcoma, a malignant tumor. You might have اللي هو onion peel, which is characteristic for Ewing sarcoma. There is also something called Codman triangle. But what you need to know is the sun ray or sunburst periosseal reaction for osteosarcoma, or onion peel or onion skin for Ewing sarcoma. Okay, so now we'll go through a few common benign and malignant tumors. So the first thing, we start with simple bone cyst. It's a benign tumor. Usually, as you can see, the age below the age of 20, and can be more in females, and it comes in the flat bone and the end of long bone. Usually, the simple bone cysts present in children with a fracture because they don't have any complaint. And after a simple fall or even very minimal trauma, they will have fracture through that bone cyst. كيس في العظم, اسمه كيس في العظم, simple bone cyst. They have the fracture. Although we have a fracture here, but if we apply our rules for benign and malignant, we can see there is no periosseal reaction. This is the fracture. The borders of the tumor is very clear. You can see it here, but the fracture is going through that. And usually this will heal by itself. No need to do any intervention. Sometimes, rarely, we need to do fixation. Aneurysmal bone cyst, the second condition, it's the same as the simple bone cyst, but the difference is that it is aneurysmal. ما معناته إن فيها blood زي الانيوريزم. No. إنها ballooning. إنها منتفخة like an aneurysm. Again, it comes in children, usually present with a painful condition. As you can see here, this is an aneurysmal bone cyst. But if you say this is a huge tumor or huge lesion, some people say, I might think this is malignant. But if you go and apply the rules of malignant and benign tumor, you can see the borders, very clear borders. You can see the inside of the tumor is very organized. As you can see here, the borders are very clear. And you can see the periosteum, there is no periosteal reaction. As you can see, very smooth edges. And there's no soft tissue involvement. So this is an aneurysmal bone cyst, a benign tumor, although it is big. And usually for these big tumors, we need to do fill it up with bone graft so it can heal. Fibrous cortical defect, again, non-ossifying fibroma. Again, it is a benign lytic lesion. This is not very here, it's very clear. As you can see, you apply the rules, non-ossifying fibroma, so you can see very clear edges, no periosteal reaction, no soft tissue, very organized matrix. So this is a benign condition. Usually does not need any treatment. Osteosteoma is it's a very, very important to know osteosteoma. Osteosteoma, again, it occurs in children. It is a benign bone tumor, but it is very painful and it gives us night pain. It's characteristic for osteosteoma to give night pain, and it is very sensitive to non-steroidal anti-inflammatory drugs like ibuprofen and Voltaren. If the patient takes that, the pain will go away or disappears immediately, and the patient might continue taking that for a few weeks. And this confirms the diagnosis. Once they stop taking the non-steroidal anti-inflammatory, the pain will come back. So it is a very common in children to have osteoma, benign bone tumor, which is very painful, especially at night. So usually it occurs around the periosteum at the edges of bone, and it is characterized by presence of a nidus. I want to show you a clear X-ray. Yeah, so you can see it here. So it is bone-forming tumor with a central nidus زي النواة. تكون ليتك. لما نتكلم عن الليتك يعني ما في بون، يعني يكون فيها فلويد. واضح؟ فلما يكون بون عندك البون الكورتكس هنا واضح بون فورمينج، ولكن في المنتصف يكون عندنا something called nidus. Nidus has the center of osteoma. As you can see here, again, there was a painful lesion here for the patient. Once we do CT scan, you can see the osteoma bone-forming benign tumor with a central nidus. واضح؟ زي النواة في المنتصف. Again, you can see another condition. طيب. انكوندروما من اسمه يعني ايش؟ كوندروما. شو نقصد بانكوندروما؟ كوندروما يعني cartilaginous benign tumor. It's a cartilaginous benign tumor. The characteristic of enchondroma or chondroma is it comes in the fingers. So if you have any benign looking tumor in the phalanges, in the finger, it is chondroma or enchondroma until proven otherwise. So most common site for enchondroma, which is a cartilaginous benign tumor, is in the finger. As you can see, no soft tissue, no periosteal reaction, no soft tissue. There is sharp edges, as you can see. طبعا هذه لأنها cartilage and bone. فيكون the inside of the tumor is like a popcorn. It's not very clear. And it's very common to present with a pathological fracture inside that tumor. As you can see here, a pathological fracture in pathological fracture. Most likely it comes in the phalanges of the finger, but can be anywhere in the bone, can be in any site, but most likely it is in the phalanges. As you can see here, it is a pathological fracture through the enchondroma. But if you apply the rules of malignant and benign, you can see this is benign because the zone of transition is very clear. You can see the border very clear, no soft tissue, no periosteal reaction, and but the bone is weak, so they have fracture. So this is called a pathological fracture through enchondroma. If you have multiple enchondromas, there is a genetic disorder called enchondromatosis, which means multiple enchondromas, Euler's disease. It's a genetic disease characterized by multiple enchondromas with huge sizes, and it runs in families. It's very, very disabling and disfiguring disease, although the tumors are benign, but it is very disfiguring. As you can see, it can affect all the joints and the bone, and the patient is usually disabled. As you can see, the huge enchondromas in the fingers. Usually patient requires debulking and amputations so they can at least function minimally. Osteochondroma, from the name, meaning that it has an osteoid origin, معنى bone origin, and chondroma, meaning having cartilage. So it's a mixed tumor between bony origin and cartilaginous origin. Also, it is called exostosis. Exostosis is osteochondroma. It looks like a fungating benign tumor. It might cause pain and irritation to the muscles and the ligaments surrounding that tumor. And excision requires to relieve the symptoms. Giant cell tumor, this is a transition between benign and malignant tumor. It is by cell origin, it is a benign tumor, but it is very aggressive tumor. Locally, it is very aggressive tumor and also can metastasize to the lung. It's called a giant cell tumor. It's a benign, very aggressive tumor. When you look at the X-ray, you can see it is aggressive tumor, huge soft tissue. So I talked about, some people would say, how would I see soft tissue on X-ray? So you can see it here. This is the soft tissue component. You can see the shadow on the X-ray very clearly at the soft tissue shadow of a benign, aggressive tumor, but the borders are still, there is narrow zone of transition, but they have destructive, they are destructive in nature, and they have big soft tissue component to it. So giant cell tumor, from its name, it is an aggressive tumor, although it is a benign in cell origin. We come to the malignant tumors. So we have the Ewing sarcoma, very common malignant tumor that comes in children and young adults, usually below the age of 20 or 25, but usually in teenagers around 15 and below. It's a malignant tumor that can metastasize to the bone marrow and to the lung and to the other sites with high rates of mortality if not treated. And one of the characteristics of Ewing sarcoma that they have a huge soft tissue component. So tumor in the bone, but it will cause a huge soft tissue component to that area. As you can see here, this is a sclerotic lesion. So we can say that the inner side is sclerotic, meaning bone-forming tumor. You can see the zone of transition is hazy. There is no sharp edges. There is significant periosseal reaction, as you can see here, and a huge soft tissue component as well. So this all goes with a malignant tumor. So this is Ewing sarcoma. We go back to the usually it gives onion peel, but in this it's not very clear, the onion peel, but you can say that there is significant periosseal reaction, which is part of the aggressive malignant tumors. Osteosarcoma, again, it's one of the very common malignant bone tumor. It comes mostly in children as well. And it has so many classifications. You don't need to go through the classification of osteosarcoma, just to know that it is a bone-forming malignant tumor. With the conventional osteosarcoma, the most common type, again, the age you can see from 10 to 20 years old, in a long bone, at the ends of long bone, and it also can be in flat bone, like the pelvic bone. It presents around the knee. It's a very common site for it. So proximal femur and proximal tibia and distal femur. And they present with knee pain and swelling. The swelling is less aggressive, the soft tissue swelling less aggressive than Ewing sarcoma. But you can see here it's a bone-forming tumor with the sunburst periosseal reaction in the proximal tibia. You can tell that this is a malignant tumor. Sometimes it presents atypically. That's why it has so many types. So, but in this condition, what can tell you that this is an aggressive tumor? The bone destruction, the amount of bone destruction. You see, part of the bone is lost. This area, part of the bone is lost. Although the transitional, the zone of transition is not very hazy. It's a little bit. You can say it is a bit sharp, but the amount of destruction will tell you that this is not a benign tumor. So you have to investigate that patient more, and it is osteosarcoma. So if we find out that a patient has a malignant, or we suspect a patient having a malignant tumor, what should we do? So the approach to approach these patients, first of all, we do local and general staging. So we have to do investigation, X-ray, CT, MRI of the knee, let's say, for this condition. Then we do CT of the systematic, so for the chest, abdomen, and pelvis, to make sure that there is no metastasis to the lung or the abdomen or the pelvis. After we complete that, and we have a differential, so we discuss with the radiologist, most likely this is an osteosarcoma based on the location and the what does the tumor look in the MRI. So once we have a list of differential diagnosis, we have to confirm the diagnosis, and we do that by taking a biopsy. A biopsy in suspected malignant primary tumor of the bone is very crucial. So if you take the biopsy by the wrong technique, you might end up by amputation, because the goal of our surgery, if we're going to do surgery, we call it limb salvage. So we want to save the limb. Otherwise, we just do amputation without any significant preserving of the limb. So our aim in treating primary bone tumor is to do limb saving tumor or limb salvage surgeries. And in order to do that, we have to be very cautious in dealing with these patients, getting the right diagnosis and getting the right way of the biopsy. ليش البيوبسي مهم جدا؟ لأنه في التيومر surgeries it's very important not to get contamination. بمعنى المنطقة هذه مثلا المريض عنده تيومر واضح. أنا I want to take a biopsy with a needle or a small يعني incision. I will go in and take a biopsy. When I do my final surgery, I have to remove all the area with negative margins to get negative margins and preserve part of the bone, so I can fix or replace the lost part. إذا واحد جاء مثلا سوى البيوبسي من الخلف posteriorly ودخل المنطقة هذه كلها وتوك بايوبسي هنا وطلع. All this area is contaminated with a tumor. So I have to remove the tumor, and the contaminated area. So I have to remove everything, and this will be, I will not be able to do limb salvage or limb saving tumors. So this is what we do. We remove part of the bone, part of the soft tissue in the proximal tibia and the distal femur, and there is special prosthesis that makes like a joint, and we remove all the tumor with negative margins. Usually patient will take chemotherapy before and after surgery to decrease any contamination and hope for cure. Multiple myeloma اختلفوا فيها هل هو is it a bone tumor or is it a hematological tumor or a hematological malignancy زي الليمفوما. Anyhow, it usually presents in the bone, or first presentation is in the bone. So multiple myeloma is a very common hematological disease, malignant طبعا disease, and present with bone lesions, usually multiple bone lesions, and it's very important. It comes in elderly patient, مهم جدا. So any elderly patient with bone lesion, yeah, usually we call it neoadjuvant chemotherapy. So we give chemotherapy before surgery, then we give chemo after surgery as well. Depends طبعا على الباثولوجي. لما ناخذ الهيستوباثولوجي and histopathology, we take the histopathology and we decide what type of chemotherapy the patient requires and how many cycles. أقدر دقيقة بس. So it depends on the pathology, the histopathology, and some staining they do, and depends how sensitive is that tumor for the chemotherapy. But usually we give neoadjuvant chemotherapy, meaning before surgery, then adjuvant chemotherapy, which is post-surgery to avoid any or try to minimize the recurrence rate. So we go back to multiple myeloma. As you mentioned, it is a hematological or a bone, malignant bone disease that comes in multiple sites of the body. It is a malignant tumor, and it comes in patients usually above 50 years old. The key point is diagnosis. Treatment is available. Curable disease. Curable treatment is available. Sometimes patient or the multiple myeloma will cause severe damage to the bone and weaken the bone. So patient will present with the pathological fracture that we need to deal with. As you mentioned, it is usually multiple myeloma. It affects multiple sites of the body with multiple lytic lesions that an elderly patient. Once you see that, you think about two things: multiple myeloma and metastatic tumor. And لو جانا مثلا elderly lady having some elbow pain, and we do X-ray and we see this picture, we say this is one of two: either multiple myeloma or metastatic disease. معناه يمكن عندها breast cancer with mets to the bone. For any elderly patient with multiple lesions in the bone, one of two conditions: either multiple myeloma, the most common, طبعا ممكن يكون أشياء ثانية, ولكن the most common, more than 99%, it is multiple myeloma or metastatic disease from breast or GI. Also, they have also skull lesions, characteristic of multiple myeloma, multiple lytic lesion in the skull. Right. Metastatic lesions, again, this is احنا خليناها للأخير بس إنها this is the most common bone tumor or bone lesions. Patient more than تقريبا 80% of bone lesions are metastatic bone tumor. واضح؟ Metastatic bone tumor بمعنى elderly patient, as you mentioned here, above age of 45. Although we're seeing more patients with younger age having primary tumor, like especially colon, thyroid and breast cancer. So patient present, عشان كده دائما نتكلم على الريد فلاجز. يجيك واحد مثلا بباك بين عمره 45 years old or 50. You should, this patient has a red flag. They might have a metastatic tumor to their spine and they presented with back pain. So you have to be very careful in evaluating these patients and to make sure that you're not missing the primary tumor. Again, they present with multiple lesions in multiple sites of the body. If they present with pathological fracture, we have to fix it, or very weak bone that is prone to fracture, we might do what we call prophylactic fixation. معناه نسوي fixation قبل ما يصير الكسر فما يكون أسهل وأسرع وأقل morbidity للpatients. Okay, any questions?